So we have the special pleasure today of a guest lecture by Dr. David Weber. Dr. Weber is a professor in medicine and pediatrics in the School of Medicine and also in the Department of Epidemiology. He's been here for 20 years now?
6 years. 26 years.
26 years. He reinvigorated the infectious disease program in the Department of Epidemiology. He's the person the state goes to when they have an outbreak investigation they need help with. And he runs the SPICE, the statewide program in infection control and epidemiology, and also the Department of Epidemiology in the hospital, North Carolina, UNC Healthcare.
Good. Thank you. So I guess our first comment should be if you're starting a research project, always very important to have a good eponym to catch everybody's attention. So SPICE is very good. But as I was telling Vic, the women who work there, now known around North Carolina as the Spice Girls. That was not our intention when we came up with that eponym. So today we're going to talk about investigating outbreaks, which of course is always fun. And we'll start off by asking you, as all epidemiologists, so here's a typical outbreak. We'll talk about it'll approximate a bell-shaped curve. And as epidemiologists, do you want to get involved at A, B, or C? So what point in time do you want to be involved in the outbreak and hear about it? Hands up for A. Hands up for B. Couple, how about C? All right, so all of you want to get involved at A, which is certainly if you want to intervene to prevent it or lower the attack rate, this is the best time to get involved. However, really, if you're a politician and public health person, really C's the best, because depending upon what the incubation period is, the exposure may have occurred weeks early. So you may not be able to do anything about that if people are already exposed and there isn't a preventive mechanism, and you're going to get raked over the coals in the newspaper for, why did another 900 cases appear when you knew about it then? The answer is we may not be able to prevent the infections at a later date. So if this were mumps, an outbreak in a high school, we have no post-exposure prophylaxis for mumps, and if they're in that 2-week incubation period, there's just nothing you can do. They're going to get disease or they're not. Well, let's just give some examples now of international, national, and local outbreaks. So let's start with SARS. Here was the outbreak curve for SARS. And it was actually a little bit of a bimodal curve. And you can see here it started in early January of 08, ended up in sort of May of 08. Certainly the curves approximate the second portion, really typical bell-shaped curve. And just want to point out to you when people say, what does it really matter if one person arrives here in the United States tomorrow, and each week in the United States we have something like 1 million people arriving from abroad. And so what if they have Ebola virus or some other highly infectious virus? Well, keep in mind here, there's A. Person A is a physician who came from Guangdong province in China and stayed at the Metropole Hotel in Hong Kong, one person. And that one person then infected, you can see on that little circle, all the people who are listed around that circle. So he infected F, G, K, I, E, D, C, B, J, and H. And those people then went on to Canada and Ireland, United States, Singapore, Vietnam. Many people went into Hong Kong, which had the initial and worst part of the outbreak. But all the cases of SARS, with the exception of those that were occurring in China, everywhere else around the world, all were related to this one person, this physician A, who acquired disease and was highly infectious and traveled to Metropole Hotel. So again, one person, when people are susceptible, can lead to potentially a worldwide pandemic. And we need to keep in mind that HIV, which came from immunodeficiency virus, occurred when that virus jumped in Africa into human individuals. We don't know how many times that occurred, but potentially only a single time, and led to a worldwide pandemic of HIV. So overall, for SARS, there are about 8,000 people who acquired SARS, and involved 29 countries. Also, I want to point out to you here the number here for healthcare workers, that about 20% of all cases occurred in healthcare workers. So being a healthcare worker is not benign, and many, when people are sick, they go to hospitals, and who do they expose, particularly when in lesser developed countries they don't have adequate personal protective equipment. So this is one of the reasons healthcare workers are held in high esteem around the world, because it's not a risk-free profession. So what did we learn from SARS? Well, the initial detection was via an astute observer. In this case, a doctor by the name of Dr. Rabbani, who actually happened to be in Vietnam not in Hong Kong, with a WHO doctor, and noticed this increase of cases of respiratory disease and alerted the WHO. He actually acquired SARS as part of his studies and died from that disease. New diseases can involve multiple countries, continued threat from zoonotic agents, jumping species boundaries, so most of these new and emerging diseases are diseases that jump from animals to humans. Healthcare workers are at high risk. Controlling all of these diseases, developing diagnostic methods is key, because you can't tell who has it and who doesn't. And this is really the first time ever that we were able to control an epidemic, truly a pandemic, just by use of quarantine and infection control. So we had no vaccine, no treatment. Nevertheless, we were able to contain and control this disease just from good public health. Let's talk about West Nile virus. This is where the virus normally is found, in Africa, Southern Europe, and some parts of Asia. In 1999, this virus spread to the United States. It's a mosquito-borne disease, so it either came in the normal host of birds, and for those of you who have lived here a while, you'll notice there aren't many blue jays around anymore. For those of us who have lived here a long time, like Vic and myself, remember 15 years ago, lots of flocks of blue jays and crows. Where'd they all go? West Nile virus killed off 95% of the blue jays and crows in the United States. That's their normal host. But these birds in the United States were not adapted. So either a mosquito traveled to the U.S. and a hold of a ship with whatever bananas or oranges, or a bird traveled, or some person who was infected with this traveled into New York City and was bitten by mosquitoes there. And you can see in 1999 that just a few places in New England were involved. By 2000, it had spread down the East Coast and up the East Coast, involved North Carolina. By 2001, essentially every state east of the Mississippi was involved. And by 2002, it was throughout the United States. Essentially now it's an endemic disease, and we'll have it forevermore in the United States. Again, it was initial detection via an astute observer, although we've worked on a lot of these new surveillance systems that are syndromic surveillance, meaning just looking for people with fevers or diarrhea or pneumonia. I'm not aware we've ever picked up a new disease through a surveillance system. So just be a good observer. And in this case, it was a smart veterinarian in New York who said, why are all these dead crows and blue jays around, and investigated it from that standpoint. Once these diseases become established, they're likely to become endemic. Many of these diseases have increasing geographic range, so this is not a new disease to humans, but a new disease to the New World. Unusual methods of transmission may occur. So we always thought of this, if you go back and look 10 years ago, literature is quite well known, this disease in Europe, that it was a mosquito-borne disease. We now know it can be transmitted by organ transplantation, blood transfusions, mother to child, and we in fact test our blood supply, and we pick up several hundred cases each year of infected blood. Again, development of diagnostic tests is key to containment. In this case, only about 1 in 150 people are ill, and so we really under-ascertain the disease. And all of these diseases, like SARS, are public health nightmares for public health. And just to show you an example for an outbreak at our hospital, and for those of you that think these outbreaks are rare, we have an outbreak at our hospital, which we figure out usually about every 3 or 4 months. The state's always working on an outbreak somewhere. I mean, these are not rare events. They may be rare to make the newspapers, but they're happening all the time. In our case, an index case was admitted on January 11th. The day that patient was admitted, they developed nausea and vomiting. We saw our first case 2 days later, our first secondary case. Nobody bothered to call us, which is pretty typical for another couple of days. Within 12 hours of being called, we began our control measures, and the last case started symptoms on the 19th. And we actually had closed this unit, which was a psychiatric unit for children, to new admissions. So we contained the disease, but we really couldn't do anything. And here's our typical outbreak curve. There's the patient being admitted there, the first case admitted on that day, and here's sort of a typical curve. And you can see it involved both family, staff, and patients. The majority of patients in the unit were infected. A large number of the staff were infected, and some family members. Norovirus, of course, is the disease on cruise ships. Very hardy, lives in the environment quite well, very low inoculating dose. This child, by the way, being a psych patient, ran around the unit smearing feces on the wall, and you can figure out why, pretty easy why there was an outbreak. So my question for you is, all the outbreaks we've seen since that time have involved either psychiatry units or our rehabilitation unit. And although we have individual cases elsewhere in the hospital, because it's a fairly common cause of diarrhea, why are the outbreaks occurring in psychiatry and rehabilitation? So you have to figure out what's similar between psychiatry and rehabilitation. They're in opposite ends of the hospital, different staffs, different patients. So what's common about psychiatric units and a rehabilitation unit that's not common in the rest of the hospital? Yes?
Just to guess, people staying for longer periods of time?
They do stay longer periods of time, although this is a pretty explosive type of outbreak. But we certainly have a lot of patients in our ICU stay weeks or months, and our burn unit, they stay for sometimes years. What else do they do in psychiatry and rehabilitation that we don't do elsewhere? Well, it turns out there are two things. One is they walk around the units as part of their rehabilitation, so the psych units are not confined to the room. Most of our patients in the rest of the hospital are too sick to do much walking, although we like them to walk. They usually don't want to get out of bed much. And actually, both of those units also have their own cafeterias. Part of their psychiatry interventions is to sort of bond with other people for rehabilitation, learn to be able to eat independently. So they eat together, which allows transmission of a fecal-oral disease, and they wander around the units. So that's why we have the outbreaks on psychiatry and rehab. And it's such an explosive outbreak that all we can do is protect the rest of the hospital, let it run its course, and keep it from involving other units of the hospital. Because almost always, by the time we hear about it, sort of everybody's been exposed, and there's not much we can do about it. Okay, well, let's talk about some of the lessons. Why am I teaching you about this, and should you even care? So what do we learn from an outbreak investigation? Well, we learn what the mechanism and the source of the outbreak is. And like SARS, it came from bats, then to civets, and then to people. And in the case of West Nile, we talked about that, from birds to mosquitoes. We learned how to control the outbreaks, how to prevent them. We discovered new pathogens, things like Legionella, Cryptosporidium, SARS, were all discovered as a result of outbreak investigations. Tell us we need new guidelines. So you know that there just recently passed a new law about FDA inspection of food products. Why? It's mostly pushed by the E. coli 0157H7 outbreaks. It validates the current guidelines we have, that we're no longer seeing those types of outbreaks. An example will be 15% of salmonella in the U.S. was related to pet turtles. So they just said you can't buy any more pet turtles, and that reduced the outbreaks of salmonella. Just want to show you some data. These are hospital-acquired infections investigations done by the Centers for Disease Control from 1990 to 1999. And you can see they were doing about 15 a year, which is only a tiny number of outbreaks. Here were the organisms they found causing the outbreaks. You can see fungi, viruses, mycobacteria, which would be tuberculosis, gram-positive, gram-negatives, mixed organisms. Some were what we call pseudo-infections, meaning nobody actually got sick. It was just a lab contaminant. These are endotoxin, wasn't even an organism, it was a product of an organism. So just showing you the variety of different types of, essentially any type of microbial life can cause an outbreak. Here were the devices associated with them. The most common were hemodialyzers, because in those days we didn't know how to clean them very well, and they transmitted hepatitis B and C. Needleless devices, we didn't want our nurses to get stuck. We introduced new devices, and these led to outbreaks. All sorts of equipment here. You can see some involve surgery, some involve dialysis, cardiac catheterization, electroconvulsive therapy, radiology, so virtually everything we do in a hospital. And then we had intravenous anesthetics, blood products, pericardial tissue, soap. Keep in mind, soap's not sterile, and soap can get contaminated, contrast media. And the only point of showing you all this is you need to keep an open mind, because it can be almost any organism or even a chemical. And if you started doing an outbreak and it was due to arsenic poisoning, it would look just like a point source with illness and maybe fever. So even chemicals can look like bacteria. And keep an open mind as to what's causing all of this. So one example of an outbreak many years ago that they talked about where I did my training in Boston at Mass General. So at Christmas time, they used to dress up a doll as Santa Claus and send him around the hospital. And everybody would write funny notes, like psychiatry would say, obviously deluded white gentleman, thinks he's Santa Claus, can fly, and everybody would do that. So they sent some urine down to the lab from Santa Claus, and it grew salmonella. Well, there really shouldn't be something growing salmonella. Really is a pathogen. And so then they did some investigations. So they didn't want to just send pure water down. So they had colored the water with the dye that in those days was used. It was given to people, and it was used as a marker of how well the gallbladder and liver were working. So that's what they found out, and it had grown salmonella. So you're the epidemiologist. What do you want to do next? So you have some dye that's used by radiology, and at least one sample grew salmonella. So what are you going to do? All right, so first thing they did is they went down to some open bottles of dye, and they cultured them, sent them down to the lab, and some, but not all, the bottles of dye also grew salmonella, but they've been opened and sitting on the shelf. So what are you going to do next? Yep. Yeah, they did. Nobody was ill. Yeah. Well, okay, so they opened up some unopened bottles of dye, and it was contaminated too. So we talk about in the hospital intrinsic and extrinsic contamination. We talk about that for food. Intrinsic means it comes to you already infected. Extrinsic means you've infected it. So if there's an outbreak in one of the restaurants in Chapel Hill, of course, they could be because one of their workers had hepatitis and they contaminated the food there. Or it could be the food came from wherever it came from, Mexico, Guatemala, and it was contaminated. So then they called a few of the other hospitals in Boston, and they opened up some dye. Some of them also had salmonella. Then they called the CDC, and they did just what you suggested. Well, they went off. Where'd you get the dye? The bottle said it was packaged in New York City, so they flew from Boston to New York and went to where it was. Well, it turned out all they did is import the dye. They didn't do anything. They got the bottles, and they just shipped them out. So what do you want to know next? Where'd the dye come from? All right, so they got on the plane. They flew to France. And so they get to France, and it turns out that the bottles are there at this distributor in France, but it turns out they don't actually make the dye. They get in these big carboys, they put them in little bottles, they label them, and then they ship them all over the world. But when they sample both the little bottles and the big carboys, yep, they found salmonella in those. So what are you going to do next? Where'd they come from? Okay, well, that turned out to be Brazil. So they got on the plane, they flew to Brazil. There. And everyone has sort of assumed that this was sort of an organic dye made in Germany and so on. But keep in mind that products that were used in the U.S. before the first Food and Drug Administration Act, really under Kennedy, due to thalidomide, didn't have to be registered, never had to prove safety and efficacy. They sort of all got grandfathered in. So there's no safety efficacy studies of aspirin or something as an example that would meet FDA guidelines. So they get down to Brazil. It turns out the way this dye is made is during a certain season of the year, a beetle, the male beetles eat flowers that are red. They make themselves red, and this is attractive to the female beetles. And so people go around and accumulate these red beetles, and they put them in a crushing machine and extract the dye. This was an organic dye made by these beetles. There were 3 beetle crushing machines, and when they sampled the beetle crushing machines, one of them was contaminated by the strain of salmonella causing the outbreak. So what do you think the FDA did when they learned that? Besides getting a nice trip to France and Brazil? What would you do if you were the FDA director? Withdrew the product off the market, and that was the end of the outbreak. It really wasn't necessary. So again, got to keep an open mind on these things. Now, although I'm going to talk about these outbreaks as a linear process, because that's really the only way to talk about it, it's not really a linear process that you start off with initial contact, you listen to the involved parties, you do an assessment, initial assessment, how many cases, is it really important, go to the lab, as we'll talk about, then set up a study if you need to, and do a full-blown investigation. But all of these things, even though I'm going to talk about them in a linear way, are really all happening at the same time. So the first thing is when someone calls you up and says, we think we have an outbreak of, confirm the diagnosis and really find out if it is an outbreak. So you evaluate the clinical findings, you review the lab findings. A lot of times people just get confused. We have an outbreak of herpes. You're thinking herpes zoster, which is chickenpox, but it's just 2 patients who have herpes simplex, and really that doesn't cause outbreaks there. Or they tell us we have 3 cases of E. coli, but we go down to the lab, and really one's E. coli, and one's Klebsiella, and one's Enterobacter, and then you sort of stop. But, you never know what you find, because just today I was looking at a sheet from a patient, and they had a highly resistant gram-negative rod. And so I looked up the record. This is a person who had been in India for 6 months. We called the lab. They'd already sent the specimen off to the CDC for further identification. I called the CDC. This, if confirmed, will turn out to be one of the first 6 cases in the United States of this new highly resistant organism that has been described coming from India. So, you never know what you're going to find in any given day. Then you need a case definition. That is, who has the disease and who doesn't. And you start off with something simple. Case definition should be simple and easy to understand. Should they be sensitive or specific, generally, if you have to make a choice? Ideally, they're both. But if you had a choice, which would you pick for an outbreak? Sensitive or specific? To figure out the cause of the outbreak. So you want them to be specific more than sensitive, because you don't want other cases in there sort of confusing the picture when you do your analysis. And if you miss a few, that's probably okay. Ideally, it would be both. So here's the CDC. You don't have to don't reinvent the wheel. You go to the CDC for all the major diseases. They already have these done, and you just see what it is. Here's their case definition. Meningococcal disease, which is bacteria that causes meningococcal meningitis. Commonly meningitis or meningococcemia, which is the bacteria in the blood, progress rapidly to purpura-fulminans, shock and death. I'll show you that in a minute. Other things may be observed. Laboratory criteria, isolation of this organism from a normally sterile site. Okay? And they can define the case as probable or confirmed based on the lab findings there. So there's your very simple case definition, and you could look up Group A strep and rabies and tetanus and almost anything else. Of course, if it's a new disease like SARS, you've got to make your own case definition. And here's purpura-fulminans, patient with all these discolored skin lesions, which represent dead skin full of organisms. And a patient like this has a mortality of 50+%, unfortunately. Okay. Then you begin active surveillance. So when we look at reportable diseases, which this is, and physicians are legally required to report this disease, but Emily Sigbert-Bennett, who is a few years ahead of you here, did a study where she matched up what happened in hospitals in North Carolina with what actually got reported to the state, and only about 15% of diseases really do get reported. So 85% don't. So you can't trust that passive reporting. You need to move to active surveillance, meaning you get on the phone and you start calling people. You call labs, you look at medical records, you call physicians, et cetera. So when you're all familiar with the anthrax attack, turned out that first case, which occurred in Florida, the person had traveled through North Carolina. He was with his daughter. His daughter had a boyfriend at Duke. They traveled through here. We got a call from the CDC saying, we don't know where this anthrax came from. So they asked us, and they asked Duke, to go through all our emergency records for a week before he came and a week after he left to see if there were any other cases that had similar presentation. We sat there just looking through the cases. Now, we didn't find any, but that's what they mean by active surveillance. Next you need to do, you have the cases, you plot the epidemic curve in the geographic area involved, and an epidemic curve is simply a simple histogram in which you're plotting the number of cases by the onset of illness. Now, that's important. It's the onset of illness when they first had symptoms, not when you heard about that, because that's really going to be the biologically relevant number. The goal is to help you determine if the source was common, how big it is it a propagated source, what the probable incubation period is, and to determine if the problem is ongoing. So it's a simple histogram. And the advantages of doing this that you can do, let's say we do a histogram here, and we get a curve like this, and a curve like that, and a curve like that. So what you'd find out, first of all, with time, the peaks go down. Why are they going down? Let's say we had an outbreak of whatever flu at the School of Public Health. Why would the number of cases go down with time? Yeah, you get all the susceptible people, and once they're ill, they're not susceptible anymore generally. So generally, in any closed population, it'll die out. Also, you notice that the curve broadens out, and that's because what happens is if you look at short end and long end here, that you can have short periods of incubation and the longest period, so the curve tends to smear out. But the actual peaks stay the same, and this time between peak and peak is the incubation period. Why is that helpful? Once you know the incubation period of a disease, and you know it causes diarrhea, well, there are only a limited number of diseases that have a 3-day incubation period for diarrhea. That's going to exclude hepatitis A, for instance, and would exclude E. coli on 57H7, be probably too long for norovirus, but might be just the perfect time for Shigella. So that's very helpful to know that. Okay, so the time intervals are on the x-axis, number of cases are on the y-axis. If you look at the time, you have to use the appropriate time to the disease. If it's a foodborne disease where all the cases occur in 3 days, you might plot it by every 6 hours, or you'll miss the peak. If you have a disease like tuberculosis that can occur over years, you know, the curve would go all the way around the room if you plotted every 6 hours. You might plot it by every week or even every month. Okay, common source is the same origin, one person or something like contaminated meal. Propagated sources are means going person to person. That tends to give you more regularly shaped peaks, but not necessarily. These curves all approximate a normal distribution if you have enough cases. So if you have 12 cases, they're probably not going to be normal. If you have 1,000 cases, they probably are. Okay, propagated source usually means it's going person to person. Can be over a longer period of time than a common source. Even if you have irregular curves, that can still be helpful because you need to look at what was causing that. An example of irregular curves might occur whenever it rains, the water supply of the School of Public Health gets contaminated with sewage, and so it's not any set interval, but you're seeing them whenever we have a lot of rains. And sometimes you can have a common source that is a bad meal, say with salmonella, but then it can go person to person on top of that. So determining the probable period of exposure, you either need the specific disease involved, you need the means or the medians of the peaks, and the dates of onset. And the other thing you can tell when you have this is, so now that we know the incubation period here, all we have to do is go back to here, and that told us where to hunt for the source, the bad food, the person who brought the illness here, whatever we need. So here's a propagated source, single case, no secondary cases up there, and you can see it sort of looks like a normal curve, even though there are only a few cases. Here's a case of hepatitis A at week 2, and then you can see a second curve peaks at week 6, about a 4-week incubation period, and then we have a tertiary wave, third wave, about 3 weeks after that. Here's again a common source. In this case, it occurred at time X when somebody came who was infected, and then you can see a normal distribution after that. Again, keep in mind there's always going to be some low-level incident cases, so the curves are not going to be necessarily perfect. Here's common source intermittent exposure just occurring, and that you've got to sort of figure out why you're seeing these individual little peaks coming and going. So these curves can be very helpful. Okay. Now, what defines an epidemic? Well, an epidemic is defined as more than expected cases. How many cases of human rabies in North Carolina would make an epidemic? 1, right? Because we haven't had human rabies in North Carolina in at least 25 years. And how many cases of flu this year would be an epidemic? I don't know, but it would be in the hundreds or thousands certainly. So again, so this is why one of the reasons you need to do baseline surveillance, because you don't know you have an outbreak unless you have the baseline surveillance. And here's an example here. You can see here these are outbreaks of botulism, and you can see we're having about 20 cases a year. And then we jump up, not huge outbreaks, but, doubles the rates. And you can see the outbreaks related to onions and fermented products and baked potatoes. And again, if the CDC were not doing the baseline monitoring, they wouldn't know that they had the outbreaks. Yeah?
Yeah, when you say the epidemic is more than the expected number of cases, where is that expected number?
So it's in a defined geographic area. That could be whatever you want. A hospital, a school, the whole United States there.
That value, what you would expect to be that number, is that coming from the prior previous?
Yes, that's coming from some type of baseline surveillance data. So, it's out there and we may or may not know it. So let's take HPV infections, and there's no surveillance system for it. I have no idea what the actual baseline number is. There are some studies, but we don't really know. So it would be very hard to know at Student Health if we were seeing an outbreak of HPV because we have no baseline numbers to go. But on the other hand, Salmonella, Shigella, Campylobacter, hepatitis A, we do keep that data. And so the answer, if we saw X number of cases, we would know that we have a problem. Sometimes, just because we're lucky, we can detect small numbers that are still an outbreak just because we're lucky. An example would be a couple of years ago, a physician stopped me in the hall and said, I'm seeing a couple of patients, just 2 patients in the last day, both of whom have bloody diarrhea and fevers, and they're both UNC students. And I think I heard about 1 or 2 more in the hospital. So we scouted around the hospital, and by the end of the day, we had 5 patients, and we got a couple more that were not sick enough to be in the hospital from student health, and pretty soon we had 7 students, all of whom developed within a 48-hour period bloody diarrhea and fever. Ultimately, they grew E. coli 0157H7, and it was pretty quick because we went and talked to them and said, okay, again, we knew the incubation period for this disease. In the last X number of days, what did you do and where did you eat? And they were in different dorms and different classes, and some were freshmen and some were seniors, but they all ate at the same restaurant in Chapel Hill at lunchtime on one particular day. Didn't take very long to figure out that there was a problem, even though the 7 cases might have been within the expected number. So it's hard to detect those little ones unless you're lucky. Definitions. Okay. Endemic, the usual rate of diseases in a geographic area. Epidemic and outbreak really are the same thing. An excess over the expected number of cases. A pseudoepidemic is where there's really no people infected, but it's just a problem with the lab and lab contamination there. So you have to keep that in mind. Okay, so we have endemic, epidemic, or outbreak, and a pseudo-epidemic or outbreak. Okay. So then once you have your, you really do have an outbreak, then you want to communicate with the appropriate authorities. Many of these diseases are reportable. And I should say, in North Carolina, all outbreaks are reportable, period. Even if the disease itself is not a reportable disease, an outbreak is. Pneumococcal pneumonia is not. If you're at a nursing home and there are 30 people in the nursing home who develop pneumococcal pneumonia in 3 weeks, you're supposed to call the state. Do they always? No. But they are supposed to call the state. Okay. And then you perform a literature review, no sense reinventing the wheels. That tells you a little bit about it, what to go hunt for, what the usual sources of the outbreak are. So always worth going to the literature. A lot easier now in these days, obviously, if computerized literature searches. But keep in mind, what percentage of articles, if you do a PubMed search on a topic, do you pull up? It's been looked at. It's about 70% on average. So the answer is, it's pretty good. But if you really want to know, then you need to expand beyond just using sort of PubMed there. So it's pretty good. But certainly not what you need to do a dissertation on. You need to get all the literature, not just 70%. Now, we need to arrange to save any of the isolates that are available because ultimately nowadays we can molecularly type isolates one way or another, and they'll show that they're all linked. So it's not just, sometimes they'll just show it's coincidence. So if I get a call, I got 3 cases of E. coli in the surgery ICU, and I type them, and they all turn out to be totally different, then it's just bad luck that week, and there's nothing common about them. And they can prove that they came from somewhere. So if I think the water's contaminated, I can go test the water. You do have to be a little circumspect. So if the public health director thinks whatever Spanky's is having an outbreak, you think they should call them and say, we just got a report that there might be a problem. We're going to be there tomorrow morning to sample your food. Think that's a good idea? What's going to happen when he goes down there tomorrow morning? Well, they're going to tell him, gee, we decided to do spring cleaning, and we threw all our food away and scrubbed everything. But it's December. Why were you doing spring cleaning? We just wanted to be early this year. So if you really want to get these at the hospital, they'll just save them for us. But otherwise, you actually have to be proactive and not tell them and just arrive because they will throw them all out. But these really do help. So an example of being proactive here was we save all our sterile fluid isolates for years. So we got a call from the CDC or an email saying that there's been an outbreak of serratia, and we think this outbreak of serratia might be related to the use of a certain solution containing calcium supplements for people. But we're not sure. We're just wondering about that. Well, that was really easy for us. So I went down to pharmacy. I said, give me a list of every patient who got this calcium supplement in the last 3 years. And then I took the list to microbiology or to our infection control group, and I said, tell me every patient who had serratia sepsis within a week of getting this calcium solution. And then they gave me a much smaller list. I went out to microbiology, and I pulled out all those isolates of serratia, had our lab technician do the molecular analysis. Within 48 hours of getting this report from the CDC, we knew that that was true. We called the CDC, called the FDA, and we, of course, were the first group then in the United States actually to prove that this was really an association, and this was, in fact, intrinsic contamination from the manufacturer. Unfortunately, the number of cases we were seeing was so low it wasn't high enough to trigger it wasn't above background. It didn't trigger any investigations on our part. Keep detailed notes of these investigations because you will almost certainly end up in court somewhere along the way explaining what happened and why and who's at fault in our very litigious society. So you want all your ducks in a row, and you want to make sure as the epidemiologist involved that you realize every word you write on this, somebody's going to be reading in open court. So you don't really want to write things like, this guy was a real SOB and he wasn't being at all cooperative, or whatever, or patient X was really annoying and very confused. So just keep in mind everything you're writing, somebody's going to read into the open record in court. Develop a protocol for reviewing cases. If you have one case, you can figure it out. But just like doing a scientific study, you need a defined protocol. If you have 100 cases, you can't go out and start telling me, what symptoms did you have, when did they start, who did you see. You need obviously a detailed protocol and some electronic record-keeping data system to put the data in. And the typical things are age and gender and location, when the symptoms started, what risk factors they might have had for disease, what you ate, what you drank, what underlying diseases you have, and then what happened. Then you move on to review the non-cases just as above. Well, what do you care about the non-cases for the cases? Well, ultimately, you're going to try and figure out what the cause of this outbreak was. You're going to do a study, and the two study designs you're going to do are either a retrospective cohort analysis or a case control study. So you need the people infected and non-infected so that you can come up with a relative risk or an odds ratio for each of the risk factors. So if you only have data on the cases, and 90% of them, whatever, had milk that morning, that doesn't help you. Maybe 90% of everybody had milk that morning. If it's 5% of the other people, then that might help you. So you have to review the non-cases just as detailed as you do the cases. Along the way, you formulate a hypothesis about the likely mode of transmission, source, and the reservoir of pathogens. And keep in mind that this is an ongoing idea. Obviously, if it's diarrhea, fecal oral. If it's pneumonia, it's inhaled. But, just keep an open mind as you try and formulate those hypotheses. All the way along the way, you want to think about instituting temporary control measures. And again, this is really why being the state epidemiologist is a really hard thing. So you get it like I did. I called them up and said, I've got 5 students here who think they all ate at Restaurant X in Chapel Hill, and they have bloody diarrhea, and the lab's telling me it's probably going to be E. coli on 0157H7. So you are the state epidemiologist. What are you going to do with that information? Well, what's the safest thing to do to keep people from anyone else from getting ill? What are you going to do? Close down the restaurant. And I should say no group in the U.S. has more power than public health. So I would have said the IRS 20 years ago, but they sort of got reined in. For everything else, if somebody wants to arrest you and put you in jail, they have to, obviously go to a grand jury, and they have to charge you, and then they have to convict you. Nothing prevents the state epidemiologist from tacking a sign on any restaurant, Chapel Hill, or cafeteria here saying, closed. And then you sue them to open it up. There isn't anybody else who can sort of take your business away from you, and then you have to retrospectively go back and try and get it open again. That's because they don't use the power very much, and they're very reasonable, and people do want their public health protected. So, yes, that would be the simplest thing to do, go close the restaurant. Well, maybe it's wrong. Maybe it really wasn't the restaurant. Maybe it was that they were eating at a cafeteria here, or maybe they all went to somebody's birthday party, and the cake was contaminated because somebody did it. So you've now closed the restaurant. I can tell you, closing the restaurant will be front-page news in the NNO and probably make WRAL. But when you open it up 3 weeks later, that'll be on page 64, and nobody's really going to care. So you can really do lasting damage there. On the other hand, if you say, well, let's get a little information, let's wait for the lab to finalize it in 2 more days, let's go ahead and do our case control study, and now it's 4 days, and you had an ongoing problem, well, now maybe 900 other people have gotten sick. So there is no right or wrong answer here, but it's really a very tough thing to think about. Then you do either a case control or a retrospective cohort analysis. When do you do that? So let's take the case of that restaurant. Can we do a cohort analysis of who ate at the restaurant? Is there any way to know who eats at a restaurant? 100% of the people? No. So you can't do a cohort because you can't define the cohort. How do you find the controls, by the way? cases you can find when they're sick, they come to the hospital. How do you find if I'm interested who ate at the top of the hill yesterday, how do I figure out who ate there? Credit card receipts, yeah. More and more people use that. So that's actually quite a good way now of at least getting a large number of the non-cases. So that's good. So if you can define it, like if I have an outbreak in my ICU, I know everybody who's in my ICU every day going back for 50 years. I want to do a retrospective cohort study, and there'll be those infected and those not, because there's no chance of bias then. I know everybody and everyone's in the study. But if you can't define the cohort, then you do a case control study. Document the biologic plausibility of suspected reservoir and mode of transmission, which may require, some experimental studies to do there. So we had one case where one of our workers in the hospital or in the university got gonorrhea in her eye, and she worked in a lab that worked with gonorrhea, and we did some studies, and her problem was when we did all the analysis, so she would dip in the loop into the solution and plate out the gonorrhea and then flame it to kill the gonorrhea and rest it like this on the base of the pedestal for where the flame was. And we showed if she didn't do that fast enough, it would drip down the loop and then touch her hands, and then she scratched her eye, and we demonstrated that that was the problem. And so the trick was for the other workers is to keep their loop vertical in a separate tube so that wouldn't happen. Perform environmental sampling. Well, many of these infections involve food or water or the environment. Why is this all the way down here? Well, let's say I culture this carpet. What am I going to find? Is it going to be sterile? No bugs? No, they're going to be about 10 to the 5 microbes, 10 to the 7 microbes per square centimeter. How about the water fountain out here? Is that water you're drinking out here sterile? No. And how about this? I just picked this up in case I got thirsty. Is this sterile? Just regular old water bottle? No. Which has more bugs, by the way, this or the water fountain? What is that? The water bottle. Why? Because there's chlorine in the water fountain, and the accepted level that should be there would be less than 1 organism per 100 mLs, but this, because there's no chlorine in it anymore, and if there was one bug that got in here, it's going to replicate perfectly well. Fortunately, I have an intact immune system, and we don't get sick from those things. So we do the environmental sampling last when we have some suspicion what to go test. And then we'll do a molecular analysis to link whatever we think we found, the carpet, the water, the food, with the cases. And then we'll update our control measures there. Again, all of these things are happening simultaneously. We'll change policies and procedures if we need them to keep from future outbreaks, and we'll write new guidelines. FDA will write guidelines, and hopefully that will eliminate these problems. We don't assume that because we told somebody what the problem was and we thought they were going to fix it, they actually did fix it. And so we always go back and make sure they really did fix it, so we don't see it again there. Okay. And then write it up, and if it's new, publish it, and if it's not, you've just solved the problem, and that's fine. But if it's really new, you ought to go tell everybody that it's new, so they don't have the same problem. Okay. So then what are the basic principles of outbreak investigation? We said, although I've talked to you about it being linear, it's really not. All these things are happening at the same time. Once we confirm that we really think we have an outbreak, we get everyone in the same room, all the people involved, the lab people, public relations, the nurses, doctors on the unit, public health. We say, okay, what are we going to do? And everybody gets assigned different pieces. Someone will go do the case control study. Someone will set up the protocol. Someone will do the data analysis. Someone will communicate with the CDC. So all of these things happen at the same time. And it's really important to keep communication going. So when we had the 8th and last lab-confirmed case of SARS in the United States here, and SARS was an issue, we joined a call with the State Health Department, which was linked to the CDC, every day at 7:30 in the morning. And we told them what was happening, and they told us what was going on. And you really need to do that. Everything you learn about epidemiology, biostatistics applies to case control studies, just like everything else that applies to these studies. So, you need to do the studies correctly with the right statistics and two-tailed tests and all the, don't use, tests for continuous variables on discrete variables, everything you've learned. I should say on these type of outbreaks, by the way, if you're doing an infectious disease outbreak, we usually figure out what it's due to about 95% of the time. If you talk to the CDC folks for these infectious disease outbreaks, they're really good. Because one of the reasons they're good is when I talked to the person who was in charge of that for the CDC, I don't know, have you, any of you been EIS officers? Any of you planning to go join the Epidemiology Intelligence Service at CDC and work on these outbreaks? Well, it's pretty straightforward. They tell me they send the EIS officer to work out the outbreak wherever it is, Maine, Hawaii, wherever, cholera in Haiti, and they don't get to come home till they figure it out. So there's a certain impetus for figuring it out there. But when you look at non-infectious disease outbreaks, we're probably no more successful than 5%. So that drives people nuts. The state gets a call, from East Chapel Hill High, some concerned mother, and saying, I've been at the PTA meeting, and I've just learned that there are 7 people in the last year at this school who have leukemia. And I'm worried there's something they're eating or drinking or in the soil of the school that's causing this leukemia. Well, there are 20,000 high schools in the United States, and leukemia is a fairly common disease, and most schools will have nobody, but you put them on a Poisson distribution, they're going to be a few schools that have 5 and 10 and 20 cases. How do you, statistically it's a cluster, but how do you prove? Well, there are hundreds of thousands of chemicals in the environment. We don't know what the risk factors are for leukemia. It drives the health department nuts, and they get up and say, we've tested your soil for lead and arsenic, and we tested the water for this, and we don't find anything. And that's not what the families want to hear. What do you mean? What about this and this and this and this and this? And there aren't any accepted levels for what that means, and they find 2 parts per billion polyvinyl chlorides in the water, and what do you know? What do you do with that? So those are really hard to do. Okay. Meticulously keep all steps, record all your steps, review the medical literature, and maintain an open mind. So we'll talk about this in a minute, but I'll give you another one that we'll mention later. Okay? If you cut open a watermelon or a cantaloupe or a honeydew, is it sterile inside or not? Or is it contaminated? Are there bugs growing inside a watermelon? Normally. No, it's sterile. It's a seed. It's sterile. It's, and that's why, it will rot eventually, but it takes a long time. So how could you have an outbreak of, say, salmonella due to a watermelon? So that's certainly possible. So the watermelon's sterile, but the restaurant or in your home, you cut it with a knife, and you just cut your chicken up, and it's got salmonella on it. You didn't wash it, and you did it, or the same thing. Sure, that could happen. And then obviously the watermelon's not cooked, so if there's salmonella in it and it's going to sit out, people are going to eat it, they could get sick. So that's certainly possible. Any other ways? Cross-contamination? Sure. Again, think expansively. Yeah. What is that? Could be on the surface of the watermelon. They haul a truck and it's hauling chickens, and then they put the watermelons in the same truck. Could be on the outside. That's why they tell you to wash your fruit. Okay. So when the watermelons get to Safeway, and they want to pay for these watermelons from Guatemala or wherever they're from, do they go 1 watermelon, 2 watermelons, 3 watermelons? How do they decide how much to pay the distributor? They counting watermelons? Weigh up. Okay, they put the truck on a giant scale. It weighs 3 tons. They take 500 pounds of watermelons off, weigh the truck again, subtract 500 pounds of watermelon. They tell them the going price is whatever it is, $1.27 per pound, and they write out a check. Okay. You are a smart but somewhat disreputable grower in Mexico, and you want to maximize the money you make from your watermelons. What do? It doesn't cost you virtually any money or time. What are you going to do?
Add water.
Add water. And if it's this, no big deal. There's not a problem. On the other hand, if you take it from the side of the road next to the cow pasture, and you just suck it up in its syringes and inject it into the watermelons, what do you put in the watermelons? Well, your watermelons weigh 15% more. You've just increased your money, pay back 15% at virtually no time for you, but those watermelons will have whatever was in the cows. Well, that happens, I wouldn't say all the time, but it's been well reported. So again, you need to keep an open mind. We talked about that this is a non-linear process. So what are some of the methodologic issues? One, well, determining that a cluster really exists. Again, it has to be in time and space. There's a whole statistics on that, and we're not going to go into that, but CDC has a very nice MMWR in that if you want to go read about it, about how you determine a cluster exists. Eliminate that it's a pseudo-outbreak. Go to the lab, make sure that it wasn't a problem in the lab. Keep in mind, all the risk factor analysis is retrospective. So let me pick someone out here. What did you have for breakfast today?
Toast and yogurt.
Okay. And what did you have for breakfast on September 4th?
Probably a peanut butter sandwich.
So that's pretty hard. That's the problem of a retrospective analysis. It's easy to remember what you ate this morning. A week ago, who can remember? So, and how would you do a study to prove that people don't remember what they ate? If you an epidemiologic study, how would you prove that? Sure, you could do that. You could say, what did you eat here on December 7th? A month from now, ask them again, see if they match up. And that's certainly possible. What's an even better way of doing that? So what people did is they watched people go down the line with the food. They filmed them. It's perfectly legal to film someone in a common area. There's no right of privacy in a common area. And they filmed them, and then they took subgroups of those people, knowing everything that was on the tray. Some they asked it 1 day, some they asked it 1 week, some they asked it 2 weeks, and so on. They actually said, what did you eat? After about a week, people have no idea. Now, and this is true for almost anything in medicine. Common things, people have, what did you wear? You know, what route did you take to work? Unless you take different routes, people can't remember. Things like, you know, did you break your leg? People remember that, you know. So the big events, people are pretty good at. So how do you do a study if you can't ask them what they ate? Well, people are terrible at remembering what they ate a week ago. People are very good at remember what they usually eat. So you simply say, what do you usually eat for breakfast? You give them a list of foods. And, you know, some people will always have coffee in the morning. Some people never will. And you have them list as, I always do this, I never do this, or sometimes I do this. There's a lot of noise in the system, but as you'll see, that's plenty good to do an outbreak investigation. So, you know, this is all retrospective. That's a problem. You know, if you have 1,000 people who have an outbreak, then you can do really detailed analysis. Only 6 people got E. coli on 57H7. You know, Vic's going to tell you if you need more power in a study, you have 2 ways of doing it. Most commonly, you just add more people. That's pretty easy, assuming you have enough money. The other is you might get a more precise measurement, and that would work too. But you don't have any choice here. You got 6 people. There are no more people to get. And so that can be a problem. And for a case control study, you can have more controls, but, you know, there's a limit to what that's good. You also have multiple comparisons. You ask people, you know, you list all the cases and controls, and you have 50 food items. Some of them are just going to be statistically relevant. That's why when you see these papers, when they do these big studies of, you know, list all the cancers you might have had, everything you do, and then you see a study, you know, in some journal that says, you know, people who eat carrots have a lower risk of gastrointestinal cancer. Well, you have 100 food items and 50 cancers. That's what you find. Or, you know, people who eat broccoli have a higher risk of skin cancer. You know, what do you make of that? And the cases could occur over an extended period of time, meaning months. So that's a problem. Sometimes there's a new pathogen, so nothing grows. It took about 4 months to figure out the cause of Legionnaire's disease, even to grow it, even though they knew it was an outbreak. There could be new mechanisms of transmission. An example will be norovirus. I told you fecal oral disease, cruise ship disease. But it's also now known that it's probably aerosol transmitted. So an example would be we had a visitor at a hospital go into a bathroom and vomit in a garbage can, and we had other people go into that bathroom who acquire norovirus, probably just from inhaling it. And that's been described in the literature. There may be novel sources or reservoirs of the disease that we never knew about. SARS, we thought it was a civet, but turned out really it comes from bats. Sometimes outbreaks are caused by more than one pathogen. There was an outbreak at the fair in New York a number of years ago where the water supply got contaminated and had both salmonella and shigella. And so you had this funny curves because you had 2 diseases occurring, both causing diarrhea. The same etiologic agent can be transmitted by different routes with potentially different incubation sources, and sometimes disease may only occur in susceptible hosts. So all of those make these outbreak investigations a little trickier. And just to remind you, when the first patient gets ill, the incubation period is the time to the clinical disease in the next person. There's a latent period where you can't pick up the disease, and then most people become infectious of many diseases before they actually become sick. So let's start off one. We have Serratia marcescens, a gram-negative organism, among patients in a surgery ICU. One nice thing about infectious disease outbreaks, you don't really have to worry too much about statistics usually. So anyone you want to do statistics on this? Or, sorry, we believe that that is in fact an outbreak. We could do the statistics and VPs. All right. So I think we want to agree that that probably is different than the baseline period. Okay. What type of study are we going to do? Figure it out? Well, first we're going to get some information. And what type of study are we going to do? So this is in an intensive care unit. So we would look at this with a retrospective cohort because we know everybody there. So we have our patients who developed bacteremia, bacteria in the blood, patients who didn't have bacteria in the blood. Here we have odds ratios. Anything jump out at you? We see any positive associations? There are the odds ratios there. Right along here. Any of these jump out at you? Well, you have this here with exposures, procedures. Look at these right here. Fentanyl in the ICU and continuous fentanyl infusion, 31 and 42. So where, again, when I learned epidemiology from Rothman, he talked there were 3 types of odds ratios. 1, no association. 2, a big association. And many, meaning a lot. Because it's unusual, to see anything above 2 or 2.5. These are 30 and 40. That's why when I talk about some noise in the system, it really doesn't much matter. You're looking for odds ratios of 10 and 20 and 30. Okay. And how about this one? This is respiratory therapist number 18. So anyone know what fentanyl is? What is fentanyl? Yeah, no, it's pain medication. It's a short-acting narcotic medication. Okay, so we think that we're worried about the fentanyl, we're worried about respiratory therapist 18. Okay, so what do we want to do now? So we can do some more data. Here's just some further analysis. Here are all the patients, respiratory 18 here, and here's a multivariate analysis to look just for the independent risk factors. Fentanyl, 44.3, and respiratory 18. Respiratory therapist 18, a risk of 11. So what are we thinking about how these patients with fentanyl got this organism in their blood? This was given IV, the fentanyl. So what are the possibilities here? What do you want to go sample? Just as we did with the dye and the in the urine. What do you want to go sample? Yeah. So we'll go down and look at the fentanyl bottles, and we go down to the pharmacy, open up fentanyl bottles, and none of them are infected. I mean, none of them have the organism in the fentanyl bottles. What is that? Test the staff for what? And why are you worried about the staff, the employees? Okay, so they could have contaminated. Why might they do that, or how might that occur? Certainly, possibility. Not suspicious enough. So first we did molecular analysis, so it was done not in this study. And you can see here that all of those, these are all the same banding patterns. So these are all identical isolates of serratia. So just what, as you'd suspect given the outbreak curve. So these all came from the same place. So then what they did is they did the case control study. We talked about that. One therapist had been reported for tampering with fentanyl. They did a hair sample for this narcotic, and it was positive. And why did they use hair instead of blood or urine? Lasts longer, so once the hair is contaminated, it grows out, but you can sample it for as long as you have the hair. And so what was this person doing? How did the patients get infected? This person was stealing the fentanyl, either selling it or using it, filling it with water from a tap, which did have the serratia in it. So this was a purposeful diversion of the fentanyl for stealing it, either to sell or to use the narcotics. They fired this person, and that ended the outbreak. So this was purposeful diversion of that. This is not the only case that's been reported like this. A number of cases have been reported of a narcotic diversion like that. So, of course, they gave this data to the local district attorney. What did they say? Just to have you people think that how important what you're doing. They said, it's only epidemiologic data. It doesn't count for anything. They never charged this person with any crime. But the person wasn't working at this hospital. All right, gastroenteritis among football players. So here we have an outbreak curve here. Anyone believe that's a real outbreak? Here's when they ate lunch. This is a football team, not UNC, but very close to us in time. They wear dark blue colors, and so they all get sick, and they have a game. And they play Florida State. So it's interesting, they didn't list the team that got sick. They did list Florida State. They got beaten 53-3. I don't know whether it's because Duke is such a terrible football team or because they were all sick. And they actually described the people having vomiting on the field, running outside of the field with vomit all over them, and getting IVs on the field, and, on the sidelines, and running back into the game. And then the Florida State team then got sick afterwards. The only place a Florida State team the Duke people had in common was on the football field. So they didn't eat at any place together. They weren't in the same dressing rooms. So this was a case of transmission over the football field there. So who do you think got sick on the Florida State team, by the way? And why? So we get some more analysis here. Here's what they ate. Again, you can see here a case control study, lunch and dinner. And you can see here for lunch, the relative risk was 4.1. Dinner, late dinner, really there wasn't any statistical risk, breakfast to lunch. So it was lunch. They were not able to get the food to actually test it. But they did know they ate a sandwich, apple, and candy bars there. And you can see here that it was the sandwich that was the incriminated item. And look at this. So if you look at the North Carolina team, which is actually Duke, you can see that roughly the same people on offense and defense got sick. Not surprising. They were getting it from the food. It had nothing to do with position. But on the Florida team, it was the offense that got sick, not the defense. Why is that? And I'll tell you, among the offense, it wasn't the wings who were catching the balls. It was the interior linemen. Why was that? Two reasons. Yeah, so one reason was that the offense was always the ones on the field because Duke would, 3 downs and punt, because they were all sick. And then Florida State was on the team, until they got the next touchdown. So that's one reason. The other was they were actually transmitting the disease in the pile-ups, and that's mostly the interior linemen. And if you weren't in the pile-up, you weren't getting sick. So this was transmitted aerosol from the vomit on their clothes to the Florida State team there. And they actually did a molecular analysis, and they did show it was all the same, and it was Norwalk virus. So this was published. Well, here's an interesting outbreak of Malassezia pachydermatous, which causes ringworm, just local skin infection. Here, it's in a nursery. Well, this is not quite as easy. I mean, first of all, notice that this is over 2 years, and it's just 1 or 2 cases popping up over 2 years. Some infants were just colonized, meaning it was on their skin, but they weren't sick, and some was actually in the blood there. So what do we want to do now? How are we going to analyze this? What type of study? Speak up. What type of study? Do the same study every time. What type of study? Case control study or retrospective cohort study, those infected, not infected. Here are cases. Here are controls. Here are the relative risks. They're having a central line was a risk, or an arterial catheter was a risk, because that's how it got from the skin into the body. What about the nurses? Well, exposure to nurse A and nurse B were also risks. And being sicker, meaning you needed an IV, was also a risk. Look at this when they did their multivariate analysis. Had an odds ratio of 74. So when was the last time you ever saw an odds ratio, anything Vic has presented, of 74? So that's pretty good. Okay. Well, this was not narcotic diversion, but they went and did some other things. Here's the PFGE, the analysis, the molecular analysis. So these really are the same, even though they're occurring over a year. It's all the same isolate. So it clearly wasn't going patient to patient because the patients weren't overlapping in time. There was something else going on. So we got to know more about it. They went and looked at nurse A, and they sampled her dogs. And her dogs out here had the isolate on the dog. So this was dog to human colonization to the infants, and she was either not washing her hands very well or at all. And so they treated her dog, and this outbreak went away. So again, open mind. So this was a case of someone's dog leading to an outbreak in a hospital there. Okay, outbreak of drug-resistant TB, patients hospitalized with AIDS. So again, we talked about how outbreaks can occur over a long period of time. This is a 4-year outbreak back in the 80s and 90s. The A's are patients with AIDS. And so they did a little bit different type of analysis, I'll tell you. Again, here's your cases and controls there. And you can see here's an odds ratio of 52, being on the same ward at the same time as a person who had tuberculosis. So this is what led to a whole series of new federal guidelines that were published in '94 about how to protect tuberculosis in hospitals, and we still follow those guidelines, and it's because the transmission occurred in the hospital. Another way of looking at the data that we commonly do is this. So here's the patient gets admitted up here, and this is when they came in the hospital. That's when they left the hospital, and these little circles are when they got diagnosed. And what you can do is draw a line all the way through, showing there was always overlap. So this was going patient to patient to patient to patient in the hospital, because in those days, they were keeping them in the same rooms. They weren't wearing masks. They weren't isolating them. So this big outbreak occurred just because of poor infection control. Unfortunately, several healthcare workers also got TB, some of whom died of their TB. And then they did the molecular analysis here to prove these, for the most part, really were the same isolate, even though they were occurring over many years. One thing you do have to be careful of is if you only have one circulating isolate in the community, there was only one TB strain in all of New York City, then of course they're all going to look the same, and it really wouldn't prove it was related to the outbreak. But they also did some other analysis, and that was not true. So this was all multiple patients with TB and AIDS. The timing suggested person-to-person transmission. The cases were linked by molecular analysis. Okay, so Serratia marcescens in the ICU, injecting drug users, replacing narcotic. Outbreak with cantaloupes, we talked about that, and the fruit. Anthrax in a letter opener, again, keeping an open mind. One case of anthrax occurred because a letter with anthrax, when it was in the post office, bumped up against another letter. And so one woman in Connecticut got anthrax, had no exposure to anything, just because she got the wrong letter in the mail, and it came from the letter that bumped into another letter in the mail. Pulmonary disease in a Legionnaire, and was a new disease due to contamination of the cooling system. Another interesting outbreak, cryptosporidius, is a fecal-oral disease, quite common, and there was an outbreak in a hospital. And it turned out to be contamination of an ice chest freezer, where people reached in and put ice. This was intentionally contaminated by this psychotic patient with feces. And so what's the solution to keep future outbreaks like this happening in hospitals? What is that? You could do that. We went to the ice machines that you push a button, the ice comes down, and essentially it's locked. There's no way to get into the machine. So we got rid of all our chest freezers for this reason in the hospital. Again, that's why outbreaks lead to policy changes, and we implement them. Listeria in pregnant women of Spanish heritage a while back turned out to be due to cheese. And it turns out the cheesemaker thought pasteurizing the cheese changed the flavor. So he was pretty good. Most of his cheese, 90%, was pasteurized, but he added in 10% for flavor. Of course, again, if it's a bug and it's growing up, 10% is as good as 100%, and led to an outbreak, and pregnant women are more susceptible to listeria than our normal hosts. So again, here was a disease in a particular subset of people because they were more susceptible. One of your former students here, worked up an outbreak of E. coli 0157 in high school students who were making apple cider as part of a high school project. Why did they get E. coli 0157H7? It's not normally on apples. So you go to the apple orchard, and you're lazy high school students. Where do you get the apples from? The ground, because you're too lazy to climb the trees, so that's what they did. Picked them off the ground. Turned out the orchard was downhill from a cow pasture. You can imagine what was on the, and they didn't pasteurize it, what was on the apples. So that's what happened there. How about E. coli 0157H7 in children who visited the state fair in North Carolina? If anyone remembers that from a few years ago. How did they get that? Yes? The petting zoo. Okay. So just for interest there, that's right. You're the state epidemiologist. What might you do to prevent this in the future?
Actually, hand washing stations.
Right. Hand washing stations. The problem with hand washing stations, which they did do, is I personally took care of a number of these kids. One of the kids that I took care of, about a year and a half old, was running around kissing the goats. Hand washing wasn't going to help. Another one was when you put in a quarter, you get some food, and you give it out to the animals. When this one ran out of food, she was picking it up off the barnyard floor. And another one was giving some of the food to the goats and eating some of the food. So the problem is, it worked well for adults, but in fact, and when they did the case control study of risk factors, amount of time in the petting zoo, age, things like that were all statistically significant. Hand washing was not protective. So, because, they're 1 year and a half year olds, and they do things like pick off food off the ground. So the answer is the hand washing stations are great, and they probably work for an 8-year-old. They do nothing for a 2-year-old there. Okay, so in summary, confirm the diagnosis, develop your case definition, begin active surveillance, plot the curve, prove an outbreak exists, communicate with appropriate authorities, do your literature review, save the pathogens, maintain detailed notes, develop your protocol for reviewing cases, review cases and controls, form your hypothesis, institute temporary control measures, do a case control or retrospective cohort study, document the biologic plausibility, do your environmental sampling if indicated, do your molecular analysis, update your control measures, change your policies, procedures, document the efficacy of the control measures by continued surveillance, and if you're lucky, write a nice paper for the New England Journal of Medicine. Thank you very much. Any questions about outbreaks? Outbreaks? Okay, don't hesitate to call me if you have questions. Thank you.
David, thank you very much.
My pleasure.
I'm going to put the slides in Blackboard, so if you want to see them. Kelly, you going to be able to see David? Introduce you to the student who's doing the outbreak exercise that she's been working on for an honors project.
Sure.
So Dave, this is Kelly Pace. Hey. Brad and Janae, I'll need about 10 minutes to go and open it up for people.
So, just so I'm clear, the students have two different evaluations that they're going to be doing. One for the students and then one that the school sends for the, one for their group.
Well, there's peer evaluation. That's the same as they did in the middle of the semester. The other one is an end-of-course evaluation.
But that's the one from the school, not from you?
It's not from me, it's from the university, actually. In fact, has anybody received the evaluation in email from the... And have you looked at the form?
No.
Would you please see if Brad and Janae are on it?
We've received a lot of evaluations from
You're in the classroom. First, we don't give it I don't know. I mean, the Office of Institutional Research in the university has an evaluation system. The School of Public Health decided to use it for this semester. And unfortunately, they don't say anything to me about it. So I don't know.
Okay.
And they don't say anything to our registrar, so he doesn't know. So have you got any emails saying, please evaluate FE600?
I'll have to, you must have, right? Yes, sure.
Thank you.
No problem. Thank you very much.
Thank you very much. I should have asked about that earlier.
I wasn't quite sure if there was going to be another one for us to tell them about, or so I guess we have it.
Well, I have to see it to know that you're on it, because if you're not on it, then there's going to be another one. And unfortunately, I forgot. I didn't want to send an email to the whole class because I'd get maybe a deluge of them, but I thought forgot I should have asked some folks. Great. Just in time. Good. Yeah. Well, it's good because otherwise you'd get an F in Bio 600 or something. You're very welcome. Thanks for coming to the lectures.
Have a good holiday if I don't see you.
Thank you. You too.